Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 263 of our pharmacotherapy series, which majors in urinary tract infections. The first question reads, T.W.O is a 28-year-old woman with a history of recurrent urinary tract infections who now exhibits a new Escherichia coli urinary tract infection. Her last episode occurred 5 months previously. Her current infection is treated with TMP-SMX for 10 days. A repeat urinalysis was scheduled for the completion of antibiotic therapy, but she cancelled her appointment because she felt fine. 12 weeks later, she returns to the clinic with signs and symptoms of another urinary tract infection. The only other medication she has taken is an oral contraceptive. Why would culture and sensitivity testing of a urine sample be especially useful at this time? Recurrent infections develop in approximately 20% to 30% of women with acute cystitis. Repeat culture and sensitivity data should help determine whether this infection represents a relapse or a reinfection. Relapse refers to a recurrence of bacteriuria caused by the same microorganism that was present before initial therapy. Most relapses occur within 1 to 2 weeks after the completion of therapy and are caused by persistence of the organism in the urinary tract. Relapses often are associated with an inadequately treated upper urinary tract infection, e.g. medication non-adherence, structural abnormalities of the urinary tract, or chronic bacterial prostatitis. Reinfection implies recurrence of bacteriuria with a different organism than was present before therapy. Reinfections can occur at any time during or after the completion of treatment, but most appear several weeks to several months later. Approximately 80% of recurrences are caused by reinfection. Reinfection is generally caused by introital colonization with enterobacteria, say from the lower intestinal tract. Of these, Escherichia coli is the most common. Certain Escherichia coli strains have been shown to adhere to vaginal epithelial cells and, in women with recurrent urinary tract infection, adherence of these organisms to epithelial cells is increased. Considering T.W.O was symptom-free for 8 weeks suggests that this is a reinfection, rather than a relapse. Patients with reinfection should be investigated for modifiable predisposing factors such as use of a diaphragm with or without spermicides. Patients with frequent reinfections should also be evaluated for risk factors such as anatomical abnormalities, undiagnosed glucose intolerance or diabetes, or other factors. The next question reads, pending the culture and sensitivity test results, what therapy should be instituted in T.W.O? T.W.O has a history of recurrent infections and now probably has a reinfection. Because reinfection is not caused by failure of previous therapy, TMP-SMX may be a reasonable choice once again. The probability that a resistant organism will be responsible for the infection increases when the interval between infectious episodes is short. If several months elapse between each episode of antimicrobial therapy, normal fecal bacterial flora become re-established and the risk of infection with resistant pathogens is reduced. The alteration of fecal flora caused by the sulfonamides makes these drugs poor choices for repeated use in cases of frequent reinfection, especially when culture and sensitivity results are unknown. The development of bacterial resistance also may limit the usefulness of these agents for chronic antimicrobial therapy. However, because her most recent infection was 12 weeks ago and the urinary tract infection prior to that was 5 months earlier, TMP-SMX would again be a reasonable choice at this time. The next question reads, if T.W.O exhibited an adverse reaction to TMP-SMX, what are some other therapeutic alternatives? Nitrofurantoin is highly effective against Escherichia coli with relatively low rates of resistance, less than 10%, in most geographic areas. It does not significantly alter the fecal or introital flora, and the development of resistance in previously sensitive strains does not often occur. Therefore, it is generally a useful agent for the treatment of recurrent Escherichia coli, Staphylococcus saprophyticus, and Enterococcus infections. The fluoroquinolones also are useful in this setting, especially in geographic areas with high rates of TMP-SMX resistance. Their widespread use should not be encouraged for reinfections as in T.W.O in light of their high cost and concern regarding selection of resistant organisms. Cephalosporins e.g., cefuroxime, cefpodoxime proxetil, and trimethoprim have also been recommended as alternative agents in this setting. The next question reads, greater than 10 power 5 bacteria per milliliter of Proteus mirabilis, sensitive to ampicillin and TMP-SMX, are cultured from T.W.O's urine. 1 week after completing her second course of TMP-SMX therapy, signs and symptoms of a UTI again appear. Pending culture and sensitivity results, TMP-SMX is again prescribed. Is this still a reasonable medication for T.W.O at this time? Because the Proteus mirabilis cultured during the last recurrence was still susceptible to TMP-SMX, this agent would again be a reasonable choice until culture and sensitivity test results are obtained. Alternatively, use of a different agent, e.g., nitrofurantoin, or fluoroquinolone could be considered because the relapse occurred within 1 week of completing the previous treatment and resistance may have developed. Additional reasons for treatment failure, including failure to adhere to previously prescribed medication regimens, should also be investigated in patients with apparent recurrent infections. The next question reads, how long should antibiotic therapy be continued in T.W.O for her relapsed infection? The duration of therapy for relapsing infections usually is 14 days. In patients who relapse after a second 2-week course of therapy, treatment for 6 weeks should be instituted. If relapse occurs after a 6-week course, some experts recommend longer courses of 6 months to 1 year. These prolonged courses should be reserved for children, adults who have continuous symptoms, or adults who are at high risk for experiencing progressive renal damage. Asymptomatic adults without evidence of obstruction should not receive these longer courses. T.W.O should be treated for at least 2 weeks and perhaps as long as 6 weeks. The next question reads, although T.W.O tolerated TMP-SMX well during her previous treatment, on this occasion she experiences significant nausea and vomiting after taking the medication. Would trimethoprim alone be an appropriate substitute for TMP-SMX in the treatment of T.W.O's infection? Trimethoprim alone and in combination with sulfamethoxazole is active in vitro against many of the Enterobacteriaceae associated with urinary tract infection and is an effective alternative to TMP-SMX in the management of both acute and chronic urinary tract infection. It would be especially appropriate for T.W.O because GI intolerance to TMP-SMX is most commonly attributed to the sulfamethoxazole component, and trimethoprim is associated with a lower incidence of side effects. Some concern exists for the potential development of resistant organisms, but studies using trimethoprim alone have failed to demonstrate a significant increase in bacterial resistance. Trimethoprim is used for the treatment of acute, uncomplicated urinary tract infection in a dosage of 200 mg per day. The next question reads, T.W.O was treated successfully with trimethoprim for 6 weeks. Is prophylactic antimicrobial therapy indicated? If so, how long should it be continued? Cases of chronic urinary tract infection in adult patients may be managed by treating each recurrent infection with an appropriate antibacterial drug or by administering chronic, low-dose prophylactic therapy. The frequency of urinary infections probably is the main determinant of whether chronic suppressive therapy should be used, because repeated treatment of recurrent infections eventually will result in a decreased incidence of subsequent infections. Long-term prophylactic therapy clearly reduces the frequency of symptomatic infections in nearly all patients. From a cost-effectiveness standpoint, women having more than one episode of cystitis per year may benefit from antimicrobial prophylaxis. For women with 3 or more episodes of cystitis per year, prophylaxis clearly is more cost-effective than treating individual infections. Therefore, it is recommended that chronic antimicrobial prophylaxis may be considered in any adult patient with 2 or more episodes of urinary tract infection per year. The duration of prophylactic therapy is also determined by the frequency of infection. Women with 3 or more urinary tract infections in the 12 months before a 6-month course of antimicrobial prophylaxis have a significantly higher recurrence rate, 75%, in the 6 months after prophylaxis than women who have had only 2 infections in the 12 months before prophylaxis, 26% recurrence rate. Therefore, prophylaxis should be continued for 6 months in patients with fewer than 3 urinary tract infections per year and for at least 12 months in adult patients with 3 or more urinary tract infections per year. Before chronic antimicrobial suppressive therapy is initiated, active infections must be completely eradicated with a full course of appropriate antibiotic therapy. The low doses of antimicrobials used for chronic prophylaxis suppress bacterial growth but do not eliminate active infection. Furthermore, surgically correctable anatomic abnormalities that predispose the patient to recurrent infections, e.g., obstruction, stones, should be ruled out. Age also should be considered when contemplating chronic antimicrobial therapy. An asymptomatic, elderly patient taking many other medications is usually not an ideal candidate for chronic prophylactic treatment because of problems of non-adherence, cost, and potential drug interactions or toxicities. Younger patients, however, are good candidates for long-term suppressive therapy. Because T.W.O, a 28-year-old woman, has had at least 3 urinary tract infections in the past few months, has undergone extensive evaluation, and has just been successfully treated with a standard course of trimethoprim, a 12-month course of antimicrobial prophylaxis would seem reasonable. She also should be evaluated at regular intervals for recurrent urinary tract infection and for the development of resistant organisms. Although the foregoing discussion applies to antimicrobial prophylaxis in adults, the use of long-term prophylaxis of recurrent urinary tract infection in children remains controversial. One study examined risk factors for recurrent urinary tract infection and associations with antimicrobial prophylaxis in a prospective cohort study involving nearly 75,000 children 6 years of age or younger. Among the children in this study, antimicrobial prophylaxis was not associated with decreased risk of recurrent urinary tract infection. However, prophylaxis was associated with a 7.5 times increased risk of infection caused by resistant bacteria. A second study examined 576 children younger than 18 years of age with a history of one or more microbiologically proven urinary tract infections randomly assigned to receive either placebo or prophylaxis with TMP-SMX for 12 months. Children randomly assigned to receive TMP-SMX experienced a 40% reduction in urinary tract infection during the study period. This benefit was independent of underlying risk factors such as history of vesicoureteral reflux. However, other outcomes such as hospitalization, secondary infections, or evidence of parenchymal disease on renal scans were not significantly different between groups. The one exception was that children receiving antibiotics were significantly more likely to experience urinary tract infection caused by an organism resistant to TMP-SMX. Finally, a meta-analysis of 11 studies evaluating long-term antibiotic prophylaxis in children found no significant benefits of antibiotic administration overall. Based on the conflicting data in the literature, current recommendations are that long-term antimicrobial prophylaxis should not be routinely recommended for prevention of recurrent urinary tract infection in children. The next question reads, what drugs could be appropriately used for long-term suppressive therapy in T.W.O? Although numerous drugs are used for prophylaxis, TMP-SMX may be the drug of choice for chronic antimicrobial therapy owing to extensive experience, proven efficacy, infrequent toxicities, and low cost. TMP-SMX also has the effect of decreasing vaginal colonization with uropathogens. TMP-SMX single strength, either 1/2 or 1 full tablet daily, is commonly prescribed for chronic urinary tract infection prophylaxis and is an effective, well-tolerated, and convenient prophylactic regimen. Successful prophylaxis, however, is significantly decreased in patients with urologic abnormalities or renal dysfunction. Also, infections that are not eradicated by a short-term therapeutic trial of TMP-SMX are not likely to respond to a long-term regimen. Finally, enterococci may colonize introitally in patients taking chronic TMP-SMX. Fluoroquinolones are effective for chronic suppressive therapy but should be used only when antimicrobial resistance or intolerance to other recommended drugs is present. Cephalosporins also have been recommended, but they are best reserved for patients intolerant to or failing prophylaxis with other agents. When selecting a drug for chronic antimicrobial therapy, it is important to consider efficacy, the likelihood that resistant organisms will develop, long-term toxicity, convenience, and cost to the patient. Based on the available information, T.W.O could be switched to TMP-SMX. Although she has a history of GI distress because of this drug, this may not be a problem with the lower doses used for prophylaxis. If she is intolerant, trimethoprim alone, nitrofurantoin, or a fluoroquinolone also should be effective. Cranberries and probiotics have long been of interest for their potentially beneficial effects in preventing urinary tract infection. Cranberries contain known compounds, i.e., flavanols, anthocyanidins, proanthocyanidin tannins that prevent Escherichia coli from adhering to uroepithelial cells in the urinary tract. A wide variety of cranberry products, e.g., juice concentrate, juice cocktail, cranberry extracts in capsules and tablets, and different dosing regimens have been evaluated in the prophylaxis of urinary tract infection, but the results are inconclusive overall and there are no formal recommendations regarding cranberry products for prevention of urinary tract infection. A recent meta-analysis found that cranberry-containing products were effective in prevention of urinary tract infections with particular benefits seen in women, 51% reduction in risk of infections, women with recurrent urinary tract infection, 47% reduced risk of recurrences, and children, 67% reduction in urinary tract infection risk. However, this analysis also noted that available studies are quite heterogeneous, and the results of the meta-analysis should be interpreted with caution. Probiotics, particularly lactobacillus strains, may prevent colonization with pathogens associated with urinary tract infection. Studies of probiotics for prophylaxis, however, are inconclusive at this time. Lack of standardization of ingredients, i.e. purity, dosage strengths, among available products and paucity of well-designed clinical studies are among the reasons for lack of clear recommendations regarding probiotics for this use. Further research is required to clarify unanswered questions regarding the role of cranberries or probiotics in the prevention of urinary tract infection. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 264.